So what strategies, what processes can be put in place to prevent complications from anticoagulation for 30-day readmissions? There are several. Number one is you need to have an inpatient process where when you start a patient or you're having a patient that's being discharged on a oral anticoagulant, that the patient is educated. Also, before the patient leaves the acute setting, we need to make sure that the patient can afford the therapy that we're putting them on. So the patient should have the prescription filled at a pharmacy, or if it's not filled, making sure we're calling out to the pharmacy where it's going to be filled that the patient can afford the medication. Also, then patient having a follow-up call or a follow-up interaction with their clinical team once they're discharged to make sure they're taking the medication, making sure they're not having any side effects, because if they are, we should intervene and make changes to their therapy without waiting for a complication or for that readmission to occur. So making sure the patient understands, making sure prescription's in hand, and then also then following up with the patient on discharge to make sure they're appropriately taking the medication and not having side effects from taking the medication. So what team members are involved in ensuring the patient is adherent to the therapy? The team can vary depending on the resources of the health system. So if it's a closed health system, so what I mean is a managed care organization, care managers would be involved, the nurses or pharmacists that are practicing in a multidisciplinary care team could be involved. If it's a fee-for-service institution, the hospital or the acute platform would need to communicate to the ambulatory, unaffiliated office who's managing the patient on the ambulatory side with the changes that were made during the acute visit or during the hospitalization, and also then the ambulatory team not affiliated with the hospital would have to reach out to the patient to make sure they filled the medications, they're taking the therapies that were changed, and also then that ambulatory visit would be scheduled within a week of discharge from the facility. So is it unexpected for patients receiving inpatient warfarin and then bridged with low molecular weight heparin on discharge until the INR is therapeutic? Is that a cause for increased length of stay? So in institutions that do not have a robust ambulatory process, is that expected? Yes, because the hospital would be responsible for that patient to make sure the patient's therapeutic on the warfarin before discharge. If the institution has appropriate ambulatory or a robust ambulatory team that can manage the patient, there is no reason to keep the patient admitted with a subtherapeutic INR. We can bridge them on the ambulatory side with low molecular weight heparin to warfarin, just as they were in the hospital bed. And we can take care of the parameters of self-injection with low molecular weight heparin, having a family member do the injection, or actually sending nurses in to perform the injection or teach the patient again or reinforce the injection process, along with drawing blood work or a finger stick process for monitoring the warfarin. If an institution does not have a robust ambulatory management team, then yes, I'm concerned about low molecular weight heparin to warfarin, and using one of the direct-acting oral anticoagulants would be preferred, as we do not have to wait till the INR is therapeutic. Yeah, so patients that are on direct-acting oral anticoagulants do not need bridging therapy. So they're short half-life, they're fast onset of action, so the factor 10 inhibitors, the onset of action is within 2 hours. So it's almost identical to receiving a therapeutic sub-Q dose of low molecular weight heparin. So no, we do not need to bridge direct-acting oral anticoagulants.